Morning, everyone. Try again. Morning, everyone. Thank you. I've come from the Far East, otherwise known as Hull, this morning, and I'm quite nervous about this talk. I don't know why I'm so nervous. I've done hundreds of talks, but I guess it's an unfamiliar crowd, and you always get a bit anxious, and imposter syndrome is very real. So I don't have to dance. So you're not going to get the disco lights on for today? Not yet, anyway. So I've been a partner in Hull in an area called Holderness for around 16 years now. I've been a GP for about 21. And we serve about 36,000 patients, and we're evenly split in terms of the population. So about a third of those are in quaint, pretty little villages, a third of them are in semi-rural towns, and a third along the coastal region in one of the most deprived parts of Hull. And some of you might have seen the statistics in the last week about Hull being the fourth most deprived city in the UK. I'm also, for quick declarations, I'm the Vice Chair for Professional Development for the college, which means essentially I have oversight of our exam. That's why I tend not to wear white, because so many tomatoes get thrown at me. I have oversight of our annual conference, and I have oversight of all our CPD. And in the last year, I do a session a week for the NIHR, driving as a national second lead for primary care. Essentially what that means is driving research in primary care settings, not just general practice, so audiology, dentistry, pharmacology. We do that across the whole patchwork in England. And I do that for one day, half a day a week. And that's really rewarding, particularly because we are able to reach a lot more underserved areas than we ever have done before. Firstly, thank you for listening to me for the next 20 minutes. I don't have any PowerPoint slides. I literally got tired of doing PowerPoint. And I thought, okay, for the rest of the year, I'm not doing any PowerPoint. I'm just going to talk to people. It's a real honour to be with you here. And because I know that the majority of you work in those challenging environments in our healthcare system, we are the first point of call for most patients. And these patients often face the greatest barriers of health. And I guess Laura talked about many leaders being in the room, and I mentioned a few of your journeys, including Adam. And so Adam, I'm going to come to you after this because I need to speak to you. So I'm not just speaking to you as clinicians, but also as leaders in a time of what I believe is going to be profound change, and if we're not careful, possible growing inequality. So the question I've been asked to discuss today is, how does general practice respond to the growing health inequalities, yet major infrastructure change in the NHS? And I thought about this, and I think I need to stand inside this question, not outside of it, because I believe that as doctors in the deep end, we are at the margin of the NHS, or some think we are at the margin, but we're really not. We are actually the revelation in the NHS, because where I work, you can see this is where the mask slips, and you can actually see the truth of the reality of what patients face day to day. And in this year, 2025, and years before, we're faced with essentially two, call it simultaneous truths. So the first truth is general practice is the highest value activity in the entire system. Truth. The second one is general practice is structurally the most fragile, and I think the most at risk. So both are true at the same time. So the question is not how do we survive that, but how do we respond to that? I use a lot of storytelling in my talks, and this morning marks no exception, except I've changed the story in my head, because on the way here, I realised, it's the 4th of November, which is my dad's birthday. And it's a significant birthday because he's 80 today. And why's my voice shaking? It's ridiculous. He's the second eldest of a family of 9, of which there are 3 left. But he's the first one to ever make it to 80. So I rang him and I said, what are you going to do today? No, what's on the cards? He said, well, seeing as you're not coming to see me, so I'm seeing him this weekend. He said, I'm going to go for a walk around the Common in South London where he lives. And I wept. And to put it into context, I cry a lot these days. It's the whole perimenopausal thing, so it's not unusual. And the reason why I was crying is because about 2 years ago, He could not walk from this stage to the exit without crying blue murder, because he had severe arthritis, literally bone on bone, and would refuse to see his GP. Till I physically had to drag him to see his GP. Within 6 weeks of going through the front door of his general practice, he was walking out of a same-day theatre from an orthopaedic back door with a new hip and a markedly improved quality of life that allows him to go walking around the common this morning. At the very same time, in Hull, I had a patient who was 62. She had recently retired. She was a caretaker, just paid off her mortgage, was looking to her retirement. But again, she had severe left hip osteoarthritis. I referred her to orthopaedics, and she was faced with a 24-month waiting list. So she remortgaged her house. She lives along the coast, and she now, till today, remains financially disadvantaged, physically better, but still she's had to return to work to help pay off her remortgage. So essentially, in the next 15 minutes, I'm going to talk about 5 parts. The first is, inequality is not a variable, it's a system output. People say, isn't it sad, inequality, the gradient's widening? Isn't it sad, it's such a tragic accident? But let's start with the reality. In England, the gap in life expectancy, as most of you know, between the most and least deprived areas is nearly 10 years. But it's not just about how long people live, it's about how long they live in good health. People in deprived areas, as we know, are more likely to suffer from multiple long-term conditions, mental health conditions, and poor access to care. And yet the funding formula we use, the Cahill formula, doesn't reflect this complexity. But I'll come back to that in a minute. So this is just not a technical issue, it's a moral one. I've also heard people say, when you work in a deprived area, oh, it's just the unfortunate context in which we operate. But I say this, inequality is the emergent phenomenon of every unguarded design decision that the NHS makes. So I'll repeat that. Inequality is the emergent phenomenon of every unguarded design decision the NHS makes. The inverse care law in 2025, I don't think is the same as it was in the 1970s. That's my personal opinion. Because today it's algorithmic, it's engineered, demand engineered, and it's administrative. I struggled the other day to improve. We were looking at cervical smear uptake. And in a place called Withensea, which is one of the most deprived areas in Hull, it was just low and we couldn't work out what was happening. And I said to one of my sex workers, why haven't you responded to my texts, certainly like 4? And she said, Margaret, I don't exactly use my phone for, say the right word, texting. She said, I can't read. And it humbled me in a heartbeat because I hadn't thought about that. So we need to be mindful that digital journeys do not assume literacy. Appointment systems should not be rewarding low complexity or low trauma. And we need to make sure that funding models price our time as if intensity of work is flat. That needs to go. And we need to make sure that we don't entertain what I think is a middle tier of the NHS that is workload blind. So I want to define something that I think is the single most important concept in this space. We are, I think, producing structurally produced demand. And I say to my children, I said to someone last night in Manchester, oh, I don't want to ring the GP, I can never get in. And when we went through it, actually, a lot of people expect an Amazon Prime response to a long-term problems that we can't really resolve. We are where trauma lands. We're the only part of the system that doesn't get to say, you don't meet our criteria. And we don't get to bounce a patient back to anybody because they belong with us. So if you want to see how we should respond to growing health inequalities, people need to come where trauma is unbuffered, uncurated, untriaged, because that is here in what I feel is the deep end. The second part is infrastructure change is not neutral. There is a lot of talk, I was talking to Kiara this morning, about ICBs, ICSs, single neighbourhoods, multi-neighbourhoods, because of course we haven't worked in neighbourhoods before. But let me say something clearly. ICBs, ICSs, they're not inherently good or bad, but they are very, very powerful. And if they're not designed with deprivation logic at the beginning, they will wash out generalism. Not because anyone intended to. If we have a system that's designed around the average user, or use hairdresser analogies to describe GP appointment booking systems, by the way, just for the record, my hairdresser is booked up for 3 months. If we have a system that's designed around the average user, the deep end will die. Again, I must stress that is my personal opinion. If general practice is not inside the design room early, the model of care is decided before we ever see a slide deck. Some of you might be, so just going off slightly of tangent, we had a capital investment into infrastructure call from the NIHR for practices this year. About 150 practices applied, and in the room, because I was fortunate to be on the decision panel, I was one of 2 GPs of 20, but it was actually quite extraordinary how people viewed general practice. For example, why have they only got 1 PI? Why do they need a room to store or archive the box? And I had to explain to them, as an independent contractor, to store this box, I need to find some storage space, I need to find some security, make sure there's adequate heating and lighting, because that is coming out of our pockets essentially. And they were stunned. So we need to be inside the design room. The third part is the deep end is the proving ground of seriousness. So I need to, when we talk about the deep end, the rhetoric sometimes I feel, and it is a feeling, is that, oh, this is where the NHS is weak. Oh. But I would say the deep end is the quality control function of the NHS. Because if a model of service can't work in the deep end, it can't work, period. Because there's no buffer. Because this is where real life happens, where safeguarding is every day, where mental health is 24/7, and where access is a proxy word for can I survive this week. We are at a point where, and that's why I'm so pleased to be here, within half an hour, my brain was racing because of 2 conversations I've had at the table. This is where, in the deep end, where innovation must prove itself. So moving on to the 4th part, okay, so what do we actually do? So I want to discuss 5 quick things, not as a policy ask to Whitehall, but to all of you. I think we need to defend continuity as an intervention, and we need to stop apologising for continuity. It's not always easy to deliver continuity. I've mentioned the inverse care law, but where I work in Hull, and it's anecdotal, I think we have an inverse training law, because we place a lot of our registrars and trainees, and I'll declare I'm an international medical graduate myself, but I acknowledge that comes with a degree of privilege, but we're placing registrars who we identify as needing more support in the most challenging areas of the country. There's nothing wrong with that, but they do need the support, and I often find that it's lacking to the point where once they CCT, they don't stay. 9 of my 10 salary GPs in this confidential space are, if not declared they're moving, are planning to move, whether it's Canada, Australia, New Zealand, and now America, because Texas is the first state to open up its borders. So if we're not careful, if we don't create a sense of value and belonging for our next generation, we'll end up literally just training doctors to work elsewhere. The second thing is, I talked about the Cahill formula. We need to demand a weighted resource. We can't deliver equity with a flat resource per head. Weighted spend is not a luxury. Now, I've been told, it's been published that the NIHR is looking at the Cahill formula. We're not, and as a senior leader in that space, nobody can tell me who's actually doing it. But at least somebody has been tasked with this because things need to change. And the third thing, some of you would have seen a medium-term planning document that came out last week. It came out almost left field, that we didn't know it was coming. And it's a good document, it's a good framework, but we've been presented with another framework that we haven't had the opportunity to feed into or co-author. So whilst we're undergoing major transformation, digital first models, neighbourhood health initiatives, we need to be mindful that we need to be in the room, because some of my patients don't even have central heating, yet alone internet connectivity. If we're not careful, these proposed reforms could actually widen the gap. But if we act with intention, they could be the key to closing it. The next thing I want to say is we need to build the team. So I might not be popular for saying this, but I'm just going to say it. We need to build the team, not the hero GP. What do I mean by that? So a year ago, I was in a conference in South Africa, but predominantly most people in the room were from the UK, not very green. And it was a pharmacy convention. And one of the senior pharmacists stood up and said, and she's a GP turned pharmacist, and she said, I long for the day when the GP comes to the realization that the patient doesn't belong to them. And I thought, you what? But the whole room erupted into sort of rapturous applause. So I think we need to be careful how we're viewed by our multidisciplinary teams. MDT is not another just person to refer to or a phone number. We are in the same spaces, same air, same agenda, and the same patients. And the last thing is, we can define success in 10-year horizons. I mentioned the medium-term framework last week. We need long-term plans, not just short-termism, because otherwise things will not change. Inequality is longitudinal, and people's trauma takes decades to metabolize. So to close, I think the future is fixed. I don't believe this gradient is our destiny. Inequality, I think, is man-made, which means it can be changed. I've been asked by a few people in the college, why are you going all the way to Manchester to speak just for half an hour? And I said, well, to be honest with you, this is one of the most important keynote addresses I'll ever do this year, because this is where I work. I don't work at the margins. I'm in it. I live it and breathe it every day of my clinical practice. And we can't wait for permission to lead, because professionalism in itself is leadership. Generalism in itself is leadership. I don't think the deep end is the NHS's problem. The deep end is the NHS's teacher. And if we answer this moment with courage, clarity, and continuity, we, as an NHS, can come out of this period of marked infrastructure change with more equity, not less. But we need to be in that room. And I believe as doctors, and also as people from the wider care team, because we're not all doctors in this room, those of us that work in areas of deprivation, we will make it so. So thank you very much for having me, and I'm happy to take any questions.
Thank you. What a way to start our day. It's interesting, isn't it? I really loved that structurally that inequality is a system output. Canvas actually genuinely agree with that. The inequality is built and baked into our system, and it's actually not a choice that many of us have, which is quite interesting. There's lots in here, isn't there? So I was just there thinking of the cardinal formula, one of the practices that I lead. If you line up all the cardinal formula outcomes, the multiplier, I've got one practice that had a cardinal formula of 1.25, which is quite high. And the poorest practice, with the highest proportion of non-English speaking people and the highest number of chronic diseases and the biggest burden of undiagnosed mental health trauma, because it's a community that doesn't believe in it, has a cardinal formula of 0.89. And that practice has never broken even in 10 years. And we are having conversations about what do you do with that? And it's not a practice where the doctors they're brilliant. The team is amazing. It's just the economics do not stack up. And it's tangibly real, like tangibly real. It's not a kind of academic. And the number of times that I've run to now, the number of times that I've been to the ICB or to NHS England and said, look, and do you know what they've told me? If you ran your practice better, you'd have more money. I'm like, well, that's not true, is it? Have you thought about recoding? So we recoded everybody. Didn't make any difference, really. So it is structural, really structural. And I don't know about other people, but the patients that I'm bothered about most are the ones that they can't write on the form or tell the receptionist what is wrong. They don't even have language for it. They know they're not well, and they know they need to see somebody. And they often present in lots of weird ways, don't they? But how the heck do they get through this amazing, complicated system when they can't articulate it? Later in the day, we're hearing from Andrew, who's done some phenomenal research about missingness and the concept of people who are missing from our healthcare system and why they're missing. And I think that will link really well. So there's so much in this. I'm so glad you are in your space. So you are amazing, lady. You had really powerful words, and I really hope and pray that your words get exaggerated and magnified, because what you say is profound. Have we got comments or questions, or just things that we'd like to share about? Do you want to come to the front? Is that all right? Because, sorry, I should have pre-warned you, shouldn't you?
Whilst you're making your way to the front, you just mentioned Andrea, some pens just dropped. I'm like fangirling. I'm like, oh my God, what's that on the same table? It's the missingness. So, Andrea, I don't know if you know our former chair, Carrie Luden, she would start every meeting, and I know missingness is a separate concept, but she'd always say to me, Margaret, think about when you're designing or doing something in the room, who's not there? And that really resonated with me. Sorry, I'll stop talking now and get you ask your question.
Thank you. First of all, it was fully inspiring listening to you. What I wanted to just ask about was the Cahill formula. Recently, I went to a conference where they mentioned you can opt out. And, I just wondered if deprived practices should be opting out to get, better funding. Is that something?
So honestly, I've not heard about opting out of Cahill formula. All we've heard at very senior level, it is being revised, and to the organisation that's been tasked with revising it, which we still haven't quite got our heads around, is the NIHR. But as I've said before, I'm happy to share that when I asked my director, and he only has one more direct report above him, neither of us knew who's actually been tasked with this. So, but I can come back to you as soon as I know anything. But I'm not sure if there is. My understanding is that it's being revised or removed. So I'm not sure opting out would be an option, if that makes any sense.
Yeah, just because one of the GPs who was at the conference mentioned their practice was doing, the opting out scheme, whatever that kind of entails. So, I guess it would be...
Was this at the college conference?
No, so it was a Trailblazer conference, fellowship conference.
Okay.
I've got the name of the lady who did it, and I can...
Yes, sure, please, yeah. So I'd be keen to know more. I mean, you opt out, but you need to, and I guess you don't want to opt out and go from, fire into a frying pan, and that's the issue.
It's baked in. So we're going to move off Cardinal for it, but it's really baked into all the other metrics that you have in your PCN, in your neighbourhood, probably going forward. It's just written into everything, even your property costs, bizarrely. So I think it's an interesting one to consider, but I've not heard you can opt out. Have we got any other comments or questions? I really wanted to pick up about your comment about defending continuity. How? How do you defend continuity? How do you make the argument for it? It obviously makes a massive difference to both the practitioner, job satisfaction and health and everything. And it makes a huge difference to the patients. But in a system that seems to me to be driving task-based interventions rather than any kind of holistic care, how would we defend that?
And then it comes. So there's several ways, I think. I think if we can just start with here, just us having a conversation about GP training and how to improve retention, particularly in areas of high socioeconomic deprivation. My mind's racing, Laura, in terms of what I'm going to the deanery with, our deanery, in about 2 hours. Because if you can do it here in Manchester, then why can't we do it in Hull? So I think we can only look at continuity if we've got the workforce, because they're interlinked, to maintain that continuity. If the workforce aren't there or they aren't staying, continuity, it's a bit of a non-starter. That's at a very kind of basic level. I think higher up, when we engage our policy leaders, we have a GP now, be careful how I say this, we have a GP who's in the House of Lords, Sir Claire Gerarda, and I've already lobbied her significantly about certain things. I think having that voice in the places that matter and where decisions are made is really, really important. And no matter what people's opinions of her are, she is passionate about general practice and continuity. So that is a good thing. But I think we can have a whole conference on continuity. We literally could. So yeah, I think you have one.
And I just wanted to kick up on the points that you made about GP training. So I'm just wondering, what do you think we should be doing sort of in our areas strategically to maybe improve the offer for our GP trainees in terms of sort of health inequalities?
So that's a great question. But I just need to, before I try and answer the question, I just need to be clear. So with the college, this is my college hat on now, we uphold and maintain the standards of general practice. The responsibility of training is NHS England, but as a GP trainer, I have lots of ideas. So I think in terms of improving the quality, I think we need to come to the realization that Generation V, Generation Z do not want to work full time. I'm just going to say it as it is. Whether that's an effect of COVID or something else, I don't know. My kids don't want to work full time, and that's okay. I'm currently working with the college on flexible training packages, or just because I'm mindful that many people, they want to stay in general practice, but someone will start a meeting and say, well, back in my day, and you can't start a meeting like that. It just doesn't work for this current generation. I think we need to also consider what their options are. So there are so many things out there that you can do as a GP now. We've got a GP with extended frameworks that the college has just done. The one in research is coming out in a few weeks. We've got a trailblazer one. So there's so many ways that people can, not improve their portfolio, enhance their portfolio, because it's not just about just being a GP, but also just recognizing that seeing patients and just being in your cohort is actually okay. Because some people do get overwhelmed thinking that they see CT and like, oh my God, I need to go and try and do all these amazing things because that's what I need. No, I'm just like, just enjoy general practice because that's what you've been trained to do. And that is perfectly okay. And I just think it's about value and belonging. And I think I can see that disappearing quite a bit in many practices because they just want a bum on the seat to see the patients. And it's so much more than that. If we don't create that sense of value and belonging, and I can do whole talks on that, that we just won't value the next generation, which will affect, me when I need to see a GP as I grow older. Sorry, that was a really long-winded answer.
I'm going to do another rant if I can. I say to a lot of GPs when they first qualify, your base skill is being a GP. The leadership, the writing, the social media stuff is all nice, but it's not the core job. And I'd really like to see the college really value just seeing patients really well. Like, one of the things that's a balance to specialism is holding up generalism. And I think we need to hold up generalism within primary care. That actually the best doctors I know, a lot of them do a lot of medicine in their practices, and they're not in all these committees and stuff. But they are the doctors that I would want to take my family to. And I don't think you can learn enough medicine in 3 years as a GP trainee to be confident with the complexity and trauma that we see in the deep end. And I would really love to see celebration, not of the people who write and do stuff, but the people who see 6 sessions a week of complex medicine, because that is what makes a difference in inequalities. And so I'd really love to challenge the college. How do we celebrate, uphold and encourage that, particularly at the younger end? Because do you know what? That is belonging. That is a community. That is a team. That is a patient. That is Marjorie that you've got to a hip replacement. That is satisfaction. And that is equally as important. So if you're sitting here as a newly qualified person, whatever your role is, do your base really well. It's so satisfying. It's so satisfying. Anyway, let's have some more comments. Not from me.
Before, if anyone wants to step up, and that's on the background of unemployment and underemployment. So I can see why people are quite anxious about developing their portfolios early on, because they feel they have to, just to gain some employment. Sorry, I'll stop.
I loved your challenge about, do we need to ditch the hero GP? But I've got a question about it. So I'm really keen on extra people within our team, and realising that we do not hold the cards on everything, and they have amazing skills. But I have noticed that since we've been embracing a wider team and encouraging their skill development, there is a kind of sense that perhaps some of what we do in general has become more transactional and less relationship-based. Because you might speak to the pharmacist about this, or speak to the physician's associate about this, and of course people who are living in deprivation need a real holistic relationship-based care over time with continuity. My question for you is, how do we encourage those wider members of our team to see their role as being about the relationship between them and our patients as much as we do? Because I think if we don't encourage them and help them to develop those skills, we'll just end up with a kind of transactional service which doesn't serve anyone's needs.
I think you've actually answered the question in that last sentence. So one of the most impactful ways I think we can get them to develop those skills is by us demonstrating those skills. You can't be what you can't see. And I would say to us, how many times, and I know it's not practical in practice, but we often try and do peer-to-peer learning, interprofessional learning within the practice. Sometimes we'll also do some shared surgeries, not just when you're training, but also post-training, just because, actually, I wonder how Jenny next door, the MSK practitioner, and we don't do it in a threatening way, because it's all about learning off each other, right? But I'm not sure whether we create enough time and space in those environments to actually do that, because I feel that would be gold standard. We are walking a tightrope, I think, at the moment, because, 60-70% possibly of most contact in general practice is done by someone who isn't a GP. But of course, these roles expanded because we didn't have enough GPs. And now we have this paradox where we've got GPs that can't find jobs. But what we need to be mindful of is not to be pitted against each other, because that could be very divisive and destructive if we're not careful. There's enough ill bodies in this country for us to, that still can't see a healthcare professional. And the reasons why they can't are so nuanced and complex. In my surgery, we don't even have enough space. I work out of a 1930s bill. We can't get any funding for the estates. Every other week there's something leaking, or, it's quite challenging. But again, I'm going off the topic of your question. I think just leadership, good sound leadership, and not leadership where you have to go on a fancy course to do leadership, just demonstrating those behaviours in the practice as a leader and how you engage your patients will rub off on your MDT.
We've got George come up. You can ask really daft questions as well. Like, can I say, we can have a political debate, that's fine, it's a bit heavy for the first thing in the morning. We are going to have coffee in a minute, but you can also just ask Margaret, how the heck did she get to the job she's got, or anything you fancy. Is that all right? Because this is... No, I don't. I really want to know.
Yeah, first of all, thanks for your very inspiring speech. Mine is just more like a comment. So I used to work in A&E as a GP, and also we've got our patients, people that are registered with the GP. So I see so many patients turning up to A&E who aren't registered with the GP. They have shocking health problems. Should we be campaigning to those invisible patients that we don't even know about, that aren't even registered with the GP? They have even more, serious problems than the patients that we do see. We just don't know about that, turning up to A&E all the time.
Yeah, no, that's a really good point. And actually, it would tie in nicely if you do want to know how I got into this role. So I wasn't, I was, just a GP. Up until about 4 or 5 years ago, I was in my practice, doing what I had to do as a trainer, not getting very involved, and outside my practice, not getting very involved. And then COVID hit. And I was going to work one morning, kids were in lockdown at school, annoyingly so. And my daughter said to me, do you have to go to work? I said, yeah, you've got to eat. And she said, but why? Because my husband's a gynecologist. And she said, why do I have to have two parents that work in the bloody NHS? I said, well, you should be proud. They're creeping for us every Thursday. And then she said, and she pointed at the TV, she said, but you're all dying. And at that point, there were all the frontline workers, the majority who were black and brown, on the screen. And she said, I don't want you to die. And I thought, oh, Sophia, went to work. An hour later, knock on the door, Sudanese trainee. She said, I can't do this anymore. I said, what do you mean? She said, why are all the partners on the phones and we're seeing patients face to face? And then I got very defensive. Well, you got an exam. We didn't have a remote platform at that time. You need to do your CSA. And she said, but we are the ones dying. So I thought, okay. But because I was a partner, in an instant, we reversed it. So everyone, there was equity across the board. Partners, salaries, registrars, had equal number of face-to-face, phones, etc. And then I thought, well, if this is happening in the Far East, what's going on out there? And so I did a quick, dirty survey on keeping, and I got about 350 responses back. And I thought, shit, now what? So what? And I remember seeing a public health consultant called Kevin Fenton standing next to Boris, when they had the podiums. I thought, I know, I'll write to him. It's so silly. And I wrote to him, and I said, people are dying. Pregnant women are going to work, across all different ethnicities. This is really wrong. We've got no risk assessment. And that's how it literally started. So there I was, and then there was an organisation from Manchester called Caribbean Afro Health Network. And they said to me, do you mind doing some Saturday morning sessions? I'm like, well, we're not going anywhere. Yeah, why not? And every hour for the last, apart from Christmas week, they host these. In fact, I did one last week. And they do these talks. But what struck me were the missing people who turn up to A&E without a GP, who came to these sessions through their phones or friends' phones, and asked the most bizarre, what I thought were bizarre questions. And I thought, why don't you know this? And then that's how it all started. And then boom, next thing on council. And I thought college council again was a very strange, odd place. I thought, who are these people? And then through a sequence of bizarre events after that, they said, do you want to step up and become the vice chair? And I said, no, don't be daft. And they said, well, you're always telling people to step up. So if not you, then when? And I thought, okay, fine. So I'm the reluctant, accidental leader, to answer your question.
They are the best type of leaders.
I'm not sure about that, but yeah, definitely.
Have we got, should we do one more and then we'll have coffee?
Adam steps to the mic.
My question might be quite controversial.
I could go for it.
Do you think that the NHS will ever kind of solve the health inequalities issue whilst it's used as a political playing piece every 4 years in the elections?
It's a really good question. I'd like to say, I'm not sure if the NHS will solve it, and that is controversial in me even saying that, but I think they will get to a point, and when I say they, where we are too hard to ignore. Because what I've seen in the last 4 to 5 years is an absolute movement, which we are all part of, whether you feel it or not, in terms of addressing that inequality, where we're saying, actually, no, not on my watch. And I think the more voices we include, the harder it is for them to ignore that. Now, I'd like the NHS to stop being used political football, but I genuinely don't know. But what I do know is that there are more good-willed and good-intentioned people in the system than I've ever seen from when I started, not even a year, 2, 3 years ago. That I'm seeing. Yeah.
That was a really hard question. You're a good thinker. So I think we can take loads, can't we, through to today, that inequality is systematically baked in. We're going to fight for continuity,
We're going to talk honestly about what we face. We're going to tell the stories of the patients that we see and the ones we don't see, because they're really important. And that we are collectively going to hold this line that inequality matters. I think we possibly need a language shift, because I'm going to sound really rude now. I don't think the average middle-class person working in the NHS understands what we mean by inequality. I think they think a graph, like a spreadsheet that's a bit red on one of their outcome dashboard things. I don't think they know what it is to sit with a family or have another notification of death flash up on your system in the morning of somebody who you really cared about who was 50. And I think that is the stories that we need to somehow bring to life more alongside the dashboards.